Okay, fine. Okay, let's start. Today is our first lecture in topographic anatomy. Yep, I got it. Yeah, you hear me fine. Thank you. Today is our first lecture in topographic anatomy and operative surgery. And so let's start. Okay, so as I have already told some of you and some groups who hasn't attended practical classes yet, the founder of this subject of topographic anatomy is a great Russian surgeon, Nikolai Ivanovich Pirogov. So Nikolai Ivanovich Pirogov said, "Let the anatomist study human cadaver up to the smallest details. Nevertheless, he will never be able to draw students' attention to those points of anatomy which are extremely important for the surgeon, but for him, for the anatomist, yes, other things of no matter." So yes, surgeon, especially practical surgeon who performs surgeries, yes, certainly he looks at human body in different way, not just as anatomist, theoretical, who studies anatomy just for his theoretical knowledge. And so this subject will be dedicated to study clinically applied anatomy, what is extremely important for us as surgeons, as physicians, as any doctor. So this subject, topographic anatomy and operative surgery, consists of two parts. Yeah, it includes two parts. Topographic anatomy, from Greek, it's a Greek term, yes, topos means place, grapho means writing. So topographic anatomy, it is an applied morphological science that studies dimensional interposition of all the organs and tissues in different systems of the body. Operative surgery, the second part of the subject, is a science that studies methods and rules of performing surgical operations. So topographic anatomy is an anatomical basis of an operative surgery. So what I'm trying to tell you is that for the surgeon, anatomy is extremely important. So the aim of topographic anatomy is to answer the questions arising in medical specialties connected with the morphology of the human body. And unlike that anatomy which we studied in the first and in the second year, this anatomy is based on the regional principle, not systemic, but regional. So what is a region? A region of the body is an area artificially marked on the surface of the body within the limits of which the topography of deep anatomic structures is studied. So I want to draw your attention that region is chosen artificially by the scientists, yes? So to facilitate our studying and to facilitate clinical application of the science. And so there are very many regions, and we will study all of them one by one. So there are 12 regions in the head, 4 in the neck, 5 in the chest, 9 in the abdomen, and so on. So we'll study all of them during this year while we study topographic anatomy. And actually, yes, I also have told you at the practical classes that you have to describe a region according to a definite plan. So first it will be boundaries of the region or borders, yes. Then landmarks, I skipped it here, but landmarks are also important, yes. Then layers, layer by layer structure of the region. Then if we are talking about the organs, we describe its topography, like skeletotopy, holotopy, syntopy. And also, yes, if we are talking about limbs, for example, it's compulsory. We say about projectional lines, about neurovascular bundles and projectional lines of these neurovascular bundles. So this, yes, we have already known it very well, that topography consists of 3 parts. It is holotopy, skeletotopy, and syntopy. And holotopy is determination of the organ position on the surfaces of the body parts. And skeletotopy, it is a location in the relation to the skeleton. And syntopy It's like, yes, a determination of the organ position towards the adjacent organs and tissues. We will not stop here. It's like, obviously, we studied it for a very long time. And so, yes, one of the exam questions that you will have next winter, it is methods of studying of topographic anatomy. And all the methods, they are divided into invasive and non-invasive. So invasive methods are those which are accompanied by dissection of human body. And usually this method is used certainly on the cadaver material, yes? So it is just a preparation, like macroscopy, yes, to study the macroscopy, like the same method we used to study just normal anatomy. And what is specific, it is ice anatomy. Actually, ice anatomy is an invention of Nikolai Ivanovich Pirogov. When he participated in the Russian-Turkish War, he took the cadavers, he took the corpses of dead soldiers, and he... sorry, да. Так, okay, yes. So he took the corpses of dead soldiers, yes, and he put them into the fridge. And after that, when they got frozen, he was cutting them into pieces, and it allowed him to study layer by layer structure of one or another part of human body. So it's another method of studying of topographic anatomy. Also, yes, we also discussed it when we studied normal anatomy, injectional corrosional method. It's when we take a special dye which does not break down under the with the time and with the boiling, yes, and we inject it into the vessels, ducts, and so on. And after that, we start to boil the organ, and everything gets boiled, everything gets undergoes decay, yes, except this dye. And in this way, by this method, we can study peculiarities of blood supply of the organ, or maybe like some excretory ducts in kidney, in liver, and so on. So this preparation, as you see, it is a preparation of blood supply vessels of the brain. Yes, so it's the other method of studying topographic anatomy. Non-invasive methods, they are used on a live person, and it's not only used to study topographic anatomy, but for the diagnostics of different diseases, yes. So it is morphometry, anthropometry. So what is it, anthropometry, you know, yes, like we measure the height of human, his weight, different parameters, different parameters, yes. And so then radiography, X-ray, yes, diagnostics, that was invented in 1895 by William Conrad Röntgen, yes, radiography. And so here you can see actually X-ray picture, but X-ray pictures, they allow us to see some solid objects only. Here you can see X-ray picture with a contrast agent. So into the transverse colon, not transverse, into the large intestine, yes, into the colon, through the rectum, maybe not. Okay, no, so this special contrast agent, barium, usually barium, was introduced, and then X-ray picture was done to check the passage of barium along the digestive tract, yes? So here that's what you can see. So the other method, it is computed tomography, and computed tomography was invented in 1972 by Hounsfield, yes? So computed tomography allows us to study sections of human body, just like ice anatomy, but in a live person. So, and it allowed us to study anatomy much better than before. And so magnetic resonance imaging, MRI, yes, it was began to be used in 1973, yes, so MRI. If computed tomography allows us to see solid structures, bones mostly, yes, then MRI is preferable to study some liquid, not so dense, loose objects. Yes, it is MRI. So also like some very modern methods like positron emission tomography, PET scan, and ultrasonography that is quite safe. Yes, that's why ultrasonography is allowed to use even in pregnant women to study state of the fetus, condition of the fetus in the uterus, ultrasonography. And what else? And now endoscopy is widely used also to study anatomy. So this is laryngoscopy. Yes, here you can see it, like we can see vocal cords quite well, and this is epiglottis. And after that, when we enter the larynx and we pass through the trachea, here you can see bifurcation of trachea. It's bifurcation into right and left main bronchus, so you see how clearly everything is visible. So certainly for us, for modern people to study anatomy, it's much easier than for Hippocrates, who didn't have all of these facilities. Okay. Okay, and what we can say about operative surgery? The task of operative surgery is to choose the method of surgical intervention which gives the patient the best operative access with the least traumatization of tissues. I was also telling you about it at our practical classes, and the great, like Russia, as you have already noticed, has many great surgeons, and one of them it is Nikolai Nilovich Burdenko. He made the main principles, general principles of operative surgery. So to perform a surgery, we should remember these three principles. It is anatomical availability, technical possibility, and physiological propriety. Now we will talk about each of them. So anatomical availability, it is an opportunity to reach the operated organ with the least traumaticity and without injuries of vitally important structures. So for this reason, we should know topographical anatomy very well. Like, for example, we will say about it, later, that, for example, to perform interventions on kidneys, for example, we can use approach through the anterior abdominal wall, and sometimes we use it, but we use it only in case when the use of this approach will be more than the harm that will be done by this approach to the patient, because it's much closer and much faster and much safer to reach the kidney, certainly through the dissection in the lumbar region. So it is anatomical availability. Then technical possibility is the presence of technical resources, equipment, and medical facilities for effective and successful performing of surgical intervention. So that's why now we have, like, all the hospitals are divided into levels. And for example, if you need to perform transplantation of the heart, you won't do it in the village hospital. And also, if, for example, you are just first year resident, you are also not going to perform the surgery, because everything we should do for the best of the patient. Only experienced surgeon with best technical equipment should perform complicated surgeries. So physiological propriety is a knowledge and consideration of an organ function, its adaptation, and opportunities. Like, we have to realize that, for example, if there is a tumor in the lung, it's better to perform lobectomy, removal of only one lobe in the lung, than to remove the whole lung, because physiological adaptation of the patient is not limitless. Yes, it's not endless. If you remove only one lobe, as it is usually done in case of tuberculosis, any benign tumor condition of the patient, his ability to adaptation will not suffer much. And if we remove the whole lung, it will really suffer. And certainly we should understand that we cannot remove both lungs, because after such a surgery, the patient will not be able to continue his life. Yes, because, like, there will be no organ for gas exchange. Okay, this is physiological propriety. In simple words, certainly everything is much more complicated. Yes? Okay. So you also have to know what is surgical operation, because we will study many surgical operation during this here. So surgical operation, it is the certain algorithm of mechanical actions of the surgeon upon organs and tissues of a live person for medical, healing, diagnostic, yes, and reconstructive purposes. Yes, so there are three, medical, diagnostic, and reconstructive. So it consists of three main stages. Yes, we also discussed it at our practical classes. It's operative approach, so how to reach the organ, operative method or operative procedure, so how to do something on this organ, and exit of operation. These are measures to restore the integrity of tissues which were damaged during approach and during surgery as well. So surgical access or surgical approach, these are the surgeon's actions to expose an altered organ, to reach the altered organ. So as I have told you that there are there are quite many requirements to operational access or surgical approach. So the width of access should ensure the freedom of and comfort of the surgeon actions in the wound. It should be chosen with the shortest distance to the operation object. Corresponds to the direction of the main vessels and nerves. So if we know that, for example, there is superficial epigastric artery that passes in subcutaneous fatty tissue in the lower abdomen, we should try not to make a dissection through it because surgery will be complicated by bleeding. Or if we have no other choice, it is inevitable that we should dissect it, then we certainly should ligate it in time to prevent excessive blood loss. So good blood supply to the edges of surgical wound, ensuring rapid healing. Remoteness from the infected foci. So if there is some infectional focus, there is infection somewhere, and we are planning a surgery. And first of all, in case of any infection, pre-planned surgery should be delayed, yes? But if we have no choice, we should perform the surgery like it is emergency, urgent surgery, then we shouldn't make our approach, we shouldn't make our dissection through this upstairs, through this focus of infection, because by this, infection will be spread everywhere. It will go to the bloodstream, it will go to surrounding tissues, and so on. And so in the postoperative period, prerequisites for a good drainage of the wound and evacuation of the wound should be provided. So if it was surgery regarding some infection, certainly we should leave some drainage tubes inside to prevent, not to allow repeated surgery due to the generalization of an infection. So what are the factors of the choice of surgical approach? Body type of the patient correlating with the peculiarities of the organ topography. So yes, we also studied it when we studied anatomy. Yes, in persons with different body types, position of organs can be a little bit different. We were talking about it in the stomach projection, in the heart projection, yes? So then degree of development of fatty tissue. So fatty tissue actually narrows. It narrows significantly operation wound. That's why in persons with a good development of fatty tissue, in fat people, we have to make bigger surgical approach, because like this fatty tissue, very thick layer of fatty tissue, it makes like a well. And so it's very complicated to reach one or the other organ in this case. So risk of surgery operation. If we are supposing a high risk, then again, a surgical approach should be larger, because in case of any complication, we shouldn't waste time and we shouldn't lose time to dilate operation wound. Possibility of infection of the wound. We have already said about it, yes. Cosmetic consideration, so it's more important for the women, yes. Like if a few years ago, cesarean section through inferior median laparotomy was very popular, now all the women want to be beautiful, yes, and they prefer and they ask for the surgeons to have transverse approach, phalange style that won't be visible in most of cases. So compliance with the rules of ablastics. Ablastics is a law of oncosurgery that concludes complete removal of the tumor within healthy tissues to prevent metastasis. So this ablastics you will study in oncology in details, but certainly we also have to consider it. Okay, surgical procedure or operative method. So these are direct actions on the object of operative intervention aimed at eliminating the pathological focus, removal, and reconstruction of the altered organ. So basic requirements to operative reception. They are radicality, if it is possible, yes. Minimal traumaticity. So what means radicality? It means if we can, we should remove as much of the alteration as it is possible. It's not always possible in case of malignant tumors, yes, but it's again like issue of oncology. Okay, minimal traumaticity, the most bloodless, so we should remember that we shouldn't lose much blood during surgical procedure. And this surgical procedure, the result of surgical procedure should violate functioning of the organism at the least extent, providing removal of the pathological process at the same time. So the surgical procedure should be done fast, safe, and accurate, yes, let's say, so for the good of the patient. Okay, now, yes, we also have said a few words about it at our practical classes. So name of medical procedures, they usually consist of two parts. And just the name actually gives us a very deep information about what was going on during surgery. So first, it is first part, it is name of the organ on which intervention is performed. And the second part, it is name of the action that is performed on the organ. So like appendectomy, append means appendix, ectomy means removal, so it is a surgery of removal of the appendix. And so there are different, like Greek names of organs you studied at your anatomy lessons. If you don't remember, you should revise them. And now I will give you some words which mean actions of the surgeon, like a result of the surgery, yes? So tomy, it is dissection of an organ, opening of its lumen. Stomy, creation of an artificial communication between the hollow organ and external environment, that is imposition of fistula, yes. So ectomy, removal of the complete organ or its anatomically isolated part, like it can be gastrectomy, removal of the stomach, or it can be also vitrectomy, for example. Do you remember vitreous body? Yes, corpus vitreum in the eye. So it's removal of this vitreous body, just part of the organ. Yes. Resection, removal of the part of the organ not anatomically isolated. Like, for example, it can be resection of ileum, resection of I don't know, small or large intestine. So just there is an altered part of the organ, we partially remove it, it is resection. Anastomosis, creation of an artificial communication between two hollow organs. Like, for example, intervascular anastomosis between two vessels, yes, in case of injury, in case of any obstruction, yes, we remove parts with obstruction, we connect to healthy parts. It can be anastomosis in the digestive tract, like it can be entera anastomosis between two parts of small intestine. It can be gastroentera anastomosis between stomach and small intestine. It can be whatever. Yes, it is anastomosis, it's clear. It can be ureterocysta anastomosis in case of transplantation of kidney, anastomosis between ureter and urinary bladder. Yes. Okay. Then amputation. Amputation is a removal of the distal part of the limb along the bone. So along the bone, we dissect the bone into proximal and distal parts, and distal part we remove. It's not the same as exarticulation. Exarticulation, I hope it will be next, it's when we make a dissection through the joint cavity, and like distal part of the limb is removed, proximal part is left, but like through the cavity of the joint. Extirpation, complete removal of the organ with surrounding tissues, like not only the organ, but also surrounding tissues. In case of the malignant tumor, for example, in case of uterine cancer, cancer of uterus, we perform extirpation of uterus, not only uterus, but also part of vagina and the regional lymphatic node, so everything is removed, and this is known as extirpation. Raphy, it is suturing of the organ. Then synthesis, pinpoint puncture of any cavity for therapeutic or diagnostic purpose. So probably it's to remove pathological fluid, or maybe just to take a sample of it. Yes. So then plasty, it is an elimination of the defect of an organ or tissue with the help of biological or artificial materials. So we will talk about it at the next lecture, like angioplasty. Angio means vessel, plastic of vessels, yes, tendoplasty, plastic of tendons, neuroplasty, so many organs can, defects in many tissues can be replaced by means of plasty. Scopy, it is diagnostic procedure to observe an altered organ. Scopy means to watch, yes, to observe. So there are very many such surgeries, like laparoscopy, it is observation of the peritoneal cavity, thoracoscopy, observation of thoracic cavity, endoscopy, it's observation of any lumen of any hollow organ, and so on. Transplantation, transfer of organs and tissues from one organism to another, or within one organism. Within one organism, it can be skin transplantation. Yes, for example, there was a burn in one place, and like there is no skin here, and we take some part of skin from the belly, for example, from those regions where there is excessive amount of skin, and we just transplant it. Prosthetics, replacement of an altered organ or its part by its artificial analogs. Biopsy, it is extraction of sample cells or tissues for examination to determine the presence or extent of a disease. Biopsy. Okay, so now we should say a few words about classification of surgical operations. So there are many classifications. The first classification is according to the time of performing. It is emergency, urgent, and planned. So emergency operation is carried out immediately according to vital indications. Yes, so if we don't perform the surgery at once, just our patient will die. It is bleeding, asphyxia, yes, suffocation, acute surgical pathology, etc. Urgent operations performed during the first day, or no, in some books it's written up to 7 days, after the diagnosis, yes. So it's, for example, in case of mechanical jaundice, when there is an obstruction in bile excretory ducts, yes. Ectopic pregnancy, if we are talking about ectopic pregnancy, it depends on the situation. If it is already interrupted, terminated ectopic pregnancy, if tube has already been blasted, then certainly it is emergency because it's already internal bleeding. But if just by sonography, by the HCG test, we identify that there is ectopic pregnancy and still it is progressing, we have a few days to decide what exactly to do, yes? And so on. Okay, planned surgery. Planned surgeries are operations in which the outcome is practically independent on the time of completion. So it's, for example, in case of uncomplicated hernias, benign tumors, and so on. So planned surgery. And certainly the best surgery is planned surgery, because before the planned surgery, patient is examined best of all, so we can find some diseases, some conditions which do not allow us to perform surgery, or maybe we should somehow improve anesthesia, yes, something to change in it, and so on. By tasks, another classification, it is surgical operations by tasks are divided into, first of all, radical. The main goal of radical operations is the complete elimination of the cause of the pathological process. For example, in case of hernia repair, yes, we just dissect hernial sac, we put back organs, hernial content, and we make herniaplasty, and that's everything is fine. Palliative surgeries, the purpose of such operations is to partially eliminate the cause of pathological process which facilitate its course. So palliative surgery is carried out in the case of when it is impossible to carry out a radical operation. For example, it is imposition of colostomy in tumors of the large intestine. So usually palliative surgery is done in case of malignant tumors, or maybe in case when patient is exhausted, like when he is very old, when he has some very severe concomitant disease, comorbid state, yes, something another, like for example, what should we say? Yes, for example, he is very old, he has maybe hernial up. Okay, let it be. For example, he is old, he has a gastric ulcer, yes, and a few years ago, gastric ulcer was an indication for gastrectomy, but if patient is very old, then just surgeons did like stitching of this ulcer, like they were stitching a surface of the stomach above this ulcer, like to exclude it from the cavity of stomach. Yes, so this is also palliative surgery. Symptomatic surgeries are aimed at eliminating a specific symptom. For example, dissection of adhesions. It is performed in case of an impossibility of a radical or palliative operation. For example, yes, again, in case of tumors, usually adhesions are formed, and sometimes patient with many surgeries, due to the cancer, he has adhesive process in the in the peritoneal cavity, and these adhesions, they finally cause obstruction, intestinal obstruction, and to remove this obstruction, we need to dissect these adhesions, but still a tumor is left. Yes, so we just stop the symptom, remove the symptom of intestinal obstruction, and patient will continue his life, but not very long. Okay, also there are such terms as operation of choice and operation of necessity. So operation of choice is the best operation at the present stage of the development of surgery, providing optimal results in the treatment of this disease. For example, laparoscopic cholecystectomy with laparoscopic cholecystectomy. I guess it was written like gallbladder stones, something like that. Yes, in case of formation of gallbladder stones, we prefer laparoscopic cholecystectomy to laparotomic nowadays. So this is operation of choice. Okay, and the operation of necessity is a performance of a relatively simple surgical intervention adequate to the condition of the patient and the surgeon's qualification. Yes, it's what I have told you before. Yes, it's suturing of the stomach ulcer against the background of the continuous bleeding. This is operation of necessity. Also, based on the technique of implementation, all the surgeries, they are divided into single stage, two-stage, and multi-stage. So the most widely used are single-stage surgeries. It is a set of all actions to eliminate the causes of the disease is performed in one operating day, like cholecystectomy, appendectomy, anything. Most of surgeries, they are single stage. Two-stage operations are surgical operations that, in view of the patient's condition or the danger of complications, are performed sequentially in 2 operation days. For example, in prostate adenoma, prostate hyperplasia of prostate gland, yes, epicystostoma first is applied at the first stage, and at the second stage, the adenoma itself is removed. So first, like we have already said about it, yes, that this hypertrophy of the prostate gland, it causes urine obstruction, yes, and first, like patient suffers, he has traumas of urethra probably, yes, and first to facilitate state of this patient, we have to apply epicystostoma, fistula, like communication between urinary bladder and external environment, and only a few days later adenoma is removed. Sorry. So multi-stage surgeries are surgical operations performed during several operating days. For example, sequential movement of skin flaps from one area to another in plastic surgery. Okay, by operative intervention, there are expanded surgeries. It means there is an increased volume of surgical operation for the disease of one organ to the features, according to the features or stage of the process, like expanded mastectomy, for example, removal of mammary gland with all groups of lymph nodes, in case of the suspicion of cancer, of course, yes. So combined surgeries, it is an increase in the volume of surgical intervention for a disease of one organ that spreads to neighboring organ. For example, when metastasis of gastric cancer spread to the left side of the liver, then the left lobe of the liver, then we should not only perform gastrectomy, but also remove left lobe of the liver. Simultaneous surgeries, these are operations performed during one surgical intervention on 2 or more organs for various diseases. For example, stomach and extrahepatic biliary tract, gallbladder and anterior abdominal wall, and so on. For example, person has cholecystitis, these gallbladder stones, and at the same time he has umbilical hernia. Sometimes surgeons perform these surgeries at the same time. First, they remove gallbladder, then they perform herniaplasty, plasty of umbilical hernia, and these are simultaneous surgeries. Like 2 diseases are healed at the same time by one surgery, yes? Repeated surgery, it is surgical operation performed repeatedly for the same disease. For example, hernial repair with recurrent hernias of the anterior abdominal wall. Or, for example, there was peritonitis, inflammation of peritoneum, yes? And like surgeons performed laparotomy and they found the source. Like, for example, it was perforation of appendix, yes, in case of appendicitis, and they removed the appendix and they cleaned everything and they left drainage tubes, but not, and they prescribed antibiotics, so they did everything they could. But anyway, again, there is a path that goes along the drainage tubes, yes, and the patient is suffering from fever, and in the common blood count in CBC there is leukocytosis, and so surgeons are forced to perform laparotomy. So again, it means re-laparotomy to find what's going on, and again to clean peritoneal cavity, to wash it, to treat it with special antiseptics, and probably they will find an abscess, yes, and they will remove it. So this is repeated surgery, and usually it is marked with prefix re. The first one was laparotomy, the second is re-laparotomy, yes? So this is repeated surgery. By the degree of infection rate, surgical operations are divided into aseptic or clean. So these are usually planned surgeries without an entrance into the lumen of hollow organ, like herniaplasty, resection of thyroid gland, etc. Conditionally aseptic, these are planned surgeries with an entrance into the lumen of hollow organ, or repeated surgery with the possibility of the infection in the remission stage. So, for example, it is planned cholecystectomy or extirpation of uterus. Conditionally infected, these are surgeries in which there is high probability of a contact with microflora. It is like usually when we dissect in digestive tract. Yes, it is appendectomy, cholecystectomy in the case of phlegmonas or gangrenous cholecystitis, and there are infected surgeries in case of some purulent processes, like it can be pyoperitonitis, pleural empyema, and so on. Yes, pleural empyema, it is accumulation of pus in the pleural cavity. So when we perform, like, when we enter pleural cavity, like perform pleural synthesis or maybe like a dissection, then certainly it will be infected. Mm-hmm. There are also bloodless and bloody surgeries. So bloodless are operations without disrupting the integrity of the skin. For example, it's just correction of dislocation of the shoulder joint. And bloody, it's all other operations that are accompanied by a violation of the integrity of skin. Therapeutic or healing, yes? Surgeries which are performed to treat a patient from a particular disease. And so, yes, they can be radical, palliative, symptomatic. What is it? It must be symptomatic. Okay, diagnostic surgeries are performed to clarify the diagnosis, to determine the stage of the pathological process. So it can be biopsy, laparoscopy, thoracoscopy, and so on. Yes, these are diagnostic surgeries. And also there are typical surgeries when, like, surgeon, like student surgery, we can call it, when surgeon enters the something like abdomen, thorax, and everything is like in normal people. Yes, like we can see there is an appendix in right inguinal region, and everything is in its place, and there are no adhesions, and we just need to find, for example, in case of an appendectomy, we just should take the appendix to remove it, and that is all. These are typical. In that is fine, and usually they have no complications, such surgeries, but also there are atypical. If there is a non-standard operating situation, if, for example, there is a typical location of appendix, if we are still talking about appendectomy, if there are very many adhesions, if, for example, patient is obese, yes, if he's very fat, and yes, it's also a typical situation. And such surgeries require very good experience of surgeon. Mm-hmm. So there are also special operations such as microsurgical, endoscopic, endovascular, and so on. So that was about, yes. Okay, that was actually, it's not the end. Let's continue. It was the first part of our lecture. I also want to tell you a few words about surgical instruments. Although we yes, at our practical classes, we saw them and we will see them. If still we didn't meet at the museum, I will give you some information. So as I have told some of you and didn't tell those students whom I didn't see, all the surgical instruments are divided into two groups. These are instruments of general purpose, which are commonly used instruments, and they are often multifunctional, and there are special instruments which are used in particular surgical fields. Instruments of general purpose are divided into the instruments for the dissection of tissues, like scalpels, knives, chisels, and so on. There are instruments for bleeding arrest. These are, for example, ligature, needles of copper, we saw it at our museum, and the sham, hemostatic clamps, etc. There are instruments for the connection of tissues, such as needle holders, surgical needles, staplers, yes, and there are auxiliary instruments such as, for example, for the provision of exposure. These are retractors and speculi, and for holding and replacement of organs. So instruments for the fixation, these are forceps and probes. So first, let's start with the instruments for the dissection of tissues. Please, if you have any questions, please text them in the chat and I will try to answer, if you are still with me, of course. So first of all, yes, we saw this instrument, the belted scalpel at our museum, and another one, it is sharp-pointed scalpel. Yes, here you can see it. And yes, we said about it that they have a little bit different function. Belted scalpel is supposed to be used in case of large, wide dissections. Yes, and sharp-pointed scalpel is should be used for the punctures, for the different punctures, for small, precise incision. Here you can see amputation knife. We also saw it at our museum. So it serves for the amputation. Yeah, it's obviously to remove part of the limb. This is bony chisel. This is bony chisel. It also serves for the dissection of the bone. This is osteotome. This is osteotome. And so here you can see what is the difference between bony chisel and osteotome in its end. Yes? Well, okay, we'll try to see it at our museum. Okay, these are blunt-ended, as you see, Cooper's scissors curved along the plane. So blunt-ended is clear, curved along the plane is also clear, and yeah, everything is clear. Okay, here you can see another scissors. No, okay, these are sharp-ended scissors and these are blunt-ended scissors, and they have certainly different significant, different application. Yes, so this sharp-ended scissors we use when we need to cut something at the end, like something very small and at the end. And blunt-ended scissors, they used to cut the thread, for example, and at end of such scissors is blunt, not to alter surrounding tissues, for example, even the hand of the surgeon. So here you can see Lister bandage scissors curved along the edge. Here you can see it. These are bandage scissors. They are also present at our museum. They are applied to remove bandages. This is anatomical dissection bone saw, also to dissect the bones. Yes. Then also we saw this Olivekrana jiggly wire saw with handles to perform. Usually it's used in cranial surgery to connect the openings which were made by burn drill, and to finally make a big opening and to remove this part of the bone. In case of osteoplastic trepanation, it's usually used. These are Dahlgren cranial forceps, which are used for trepanation, also to remove some pieces of skull bones. These are Liston forceps. They are also serve to dissect the bones, small bones. Luer bone forceps. Here you can see it. They also can be used in cranial surgery. These are respiratories. Ferrabaph respiratories. It serves to replace periosteum. Like you dissect periosteum and you replace it, not to damage it, before the dissection of bone substance. So that's why this special instrument serves for this, to move the periosteum. This is Doyen costal respiratory, to do the same, also to remove periosteum, replace periosteum, but in the rib. This is, yes, you saw also this thing, hand drill with burr at our museum. So this is hand drill, and I told you that actually nowadays there are electric drills as well. And this is drill, and these are very many burrs, depending on the fact what actually surgeon wants. He can choose any burr, and he should put it here, insert it here, and put the end of the burr onto the skull bone and start to rotate this hand drill, and finally a small opening will be formed. This is Walkman sharp scoop, or bone curette it is also named. Here you can see it, it is even double-sided. At our museum there are two, small and large, but one-sided. Yes, it serves to evacuate bone marrow from the bone in case of osteomyelitis, for example. This is also just another variation. It is bronze sharp scoop, but its function is the same. This is trocar, Bulau trocar. It serves to make a Bulau drainage. It serves to perform pleurocentesis in case of accumulation of liquid or maybe air. In case of hydrothorax or pneumothorax, we make pleurocentesis with this Bulau trocar. Then we insert the tube for the drainage and we leave it inside this tube until all the liquid or all the air leaves. We also saw it at our museum. Who didn't see will see it tomorrow and on Friday. It is Quincke needle for spinal puncture. Here you can see how it is done. Yes, it has like a cannula and it has something like a trocar. Yes, like a needle. And when you perform a puncture, actually this is Seldinger's technique, yes, of entering. We will also discuss it at our lessons about surgery of vessels, yes. So when you insert this needle, you insert both cannula and the needle together. And when you feel that you are where you need to be, like in the subarachnoid space, for example, for the lumbar puncture, yes, you remove the needle, but you leave the cannula. And through this cannula, if you are doing it, if you do the spinal puncture to take the sample of CSF, then through this cannula, liquid starts to go out, and you should just take it. And if you are performing spinal puncture for anesthesia, then again through this cannula you can inject substances, something like something like anesthetics, yes, and anesthetics. So this is Quincke needle for spinal puncture. Instruments for bleeding arrest is the second group. It is, here you can see Billroth hemostatic forceps. I was trying to explain you that at the museum, that you see surface of the branches, internal surface of the branches in Billroth hemostatic forceps, it's like it is nearly smooth. Like these teeth which are present, they do not damage, they do not do any harm. And that's why Billroth hemostatic forceps is applied on the vessels for the temporary bleeding arrest. Like you stop bleeding, you need to do something in this vessel without blood flow, and then you remove this forceps and blood flow will be restored and nothing will happen with the vessel. Coher hemostatic forceps, it has teeth. You see, it has teeth at the end. Now it's clearly visible, and if you apply Coher hemostatic forceps, it is more secure. Yes, it's more secure. It won't. It will prevent leakage of blood, yes, from the vessel, but it will crush the tissues. And that's why usually Coher hemostatic clamp is applied on that part of the vessel that is supposed to be removed at the end of the surgery. This is hemostatic forceps mosquito type. Mosquito type, because just, yes, it looks like the end, the mouth of these mosquitoes, and it also serves for hemostasis. This is Satinsky forceps. Satinsky forceps is usually used for the abdominal aorta, like it's very big, and yes, to prevent any bleeding from the aorta. This is Fedorov forceps for the renal pedicle. In case of nephrectomy, removal of kidney, we apply Fedorov forceps onto the renal pedicle, and we start to treat each structure of renal pedicle one by one. First, arteries and vein, ureter, and so on. Yes, but first we apply this Fedorov forceps onto the renal pedicle. So instruments for the connection of tissues. Yes, first of all, these are needle holders, and this is Hegar's needle holder. Here you can see it. Yes, like everybody knows what is it, I guess. This is Matthew needle holder. This one, it's bigger. Yes, it's also present at our museum. Needles. Yes, we're talking about the needles, and we said that first of all, needles are divided into two big groups. They are traumatic and atraumatic. And traumatic needles, they have at the beginning an opening, like an opening for the thread. Like its disadvantage, as we have already said, that this diameter of this part of the needle is larger than diameter of the thread and diameter of the end of the needle. And that's why when this part passes through the wound, it dilates this wound, so it is more traumatic. But advantage of it is that this traumatic needle can be used many times, so it is multiple use needle. And here you can see traumatic piercing needle. Piercing, it pierces. The other classification of needles is that they can be piercing and cutting. Like these are just two main groups, but actually there is cutting, reverse cutting, and piercing cutting, something like that. Okay, we are now interested just that they are divided into piercing and cutting needles. And advantage of piercing needle is that while it enters, it replaces like vessels, nerves. It doesn't pass through it, it replaces it, and just it passes through the tissues of the organ where it is sent. Yes, so it is less traumatic than cutting needle. This is cutting needle. So it has a triangular section, and when it meets such vessels, nerves, tendons, it will dissect it. It will pass through it. It will not replace it. That's why usually cutting needle is used in case when we stitch some solid tissues, dense tissues, yes, and when we stitch loose tissues, we prefer piercing needles. Auxiliary instruments for provision of an exposure. So when we are performing surgery, we need good observation, yes, and that's why we use this auxiliary instruments. So yes, this is Cusco vaginal speculum. It is also present at our museum for the gynecological examination, yes, to see vagina and vaginal portion of cervix. So here you can see it is multiple use, and this one is disposable. It's plastic, and this one is metallic, but anyway, it is Cusco vaginal speculum. A liver retractor, this one, to retract the liver for during abdominal surgery. Yes, if we don't need to perform any interventions on it. This is Mikulich retractor. It is, you see, double two branches. Yes, retractor. This one. So yes, the advantage of it is that when you insert it into the wound, you can dilate it and you can leave it, and you don't need any assistant to hold it. And for example, this liver retractor, certainly somebody has, like, assistant has to hold during the whole surgery, and actually hands, they get tired, and after that you feel pain in the muscular pain, yes, if you're assistant in a very long surgery. Walkman retractor. There are different Walkman retractor, like 1, 2, and 3, 4, 2, 3, 4, 5 tools. So it depends on how big wound, how large the wound that we should retract. Yes, this is Walkman's retractor. For a BEF retractor, it's like C-shaped retractor. It's also used to retract the margins of the wound, and it is atraumatic. Like this one is very dangerous to use, yes, due to these teeth. And this one is blunt-ended, so we can use it in abdominal cavity, yes, in yes, abdominal surgery. Yeah, this is also, all of these instruments are present at our museum. This is backhouse towel forceps, as I told you, to fix towel, sterile towel that surrounds operation wound to the skin, to the skin of the patient. And instruments for the holding and replacement of organs. Well, certainly it is forceps, it's obviously, yes, and there is anatomical and there is surgical. Not only, yes, this one more, Russian forceps, it's named Russian forceps, also serves for holding the tissues. This is surgical forceps that has teeth. And so if we are talking about abdominal surgery, we can use surgical forceps only before we enter peritoneal cavity, yes? After, like, we start the dissection, we can use surgical forceps. When we enter peritoneal cavity, operation nurse takes away all the surgical forceps and gives us only anatomical. Because intestines are very fragile, yes, because all the hollow organs are very fragile, and we cannot touch organs and vessels of abdominal cavity with surgical forceps. And after we stitch peritoneal cavity, a nurse again gives us surgical forceps, because skin and subcutaneous fatty tissue, like it needs to be held firmly, and it's like rather solid, yes? So these are tenaculum forceps, uterine tenaculum forceps, Schroeder Brown. This is one tooth again, and this is two teeth. It is used to hold the cervix of uterus during some intrauterine interventions. So this is uterine, during, yes, stitching of the ruptures of the cervix, for example, after the delivery, or maybe it's during abortions, and so on. So this is uterine tenaculum forceps. This is Museau uterine tenaculum forceps, and it is also present at our museum. Yeah, just it's a little bit different, but the function is the same. This is Ellis intestinal tissue forceps. It's like, yeah, it looks very dangerous, but actually it's very soft. Like, you see that teeth, they do not join each other completely, and that's why it cannot damage intestinal tissue much. This, yes, the thing that we also saw at the museum, it is Pyre intestinal and stomach clamp forceps, so it is traumatic intestinal clamp, yeah? And there is also doyen, atraumatic. Here you can see, this is doyen. And yes, we also said at the practical classes that Pyre, that is traumatic, it is usually applied onto the part of the intestine that is supposed to be removed, yes, after the during the surgery. And doyen intestinal forceps, it is atraumatic, and it is usually used for the part which is supposed to stay, so not to crush, not to traumatize intestinal wall. Okay, so yes, these are endoscopic instruments. We are not interested in it for now. Actually, that is all I wanted to tell you today. Do you have any questions? So no questions. Yes, everything is absolutely clear as always. Okay, I'm glad. Okay. Okay, so if you have no more questions, then you may be free. So see you next week. Goodbye. Like very interesting, Chitranshi. You didn't see slides for the whole lecture, and now, like, I was doing my best. I was telling you all the things, and finally, you decided to tell me that you didn't see the slides. Uh, has anybody seen the slides? Okay, so they were visible. Okay. Yes, I will send you PDF, but next time, yes, if you have any technical difficulties, please tell us. Probably it's your problem, and but maybe it's mine. Uh-huh. Okay. Yes. Okay. Yes, I will send you PDF later. Mhm. Okay. So goodbye.